After my disclosures, I will start from the end of the previous talk, saying that yes, we know that poor patient-ventilator interaction is associated with poor outcome in terms of prolonged mechanical ventilation, ICU, and hospital stay, as well as ICU and hospital mortality. So we should be able to detect this problem at the bedside, and actually interpretation of standard ventilator waveforms was originally described in the 90s, and 10 years later this case was suggested that every intensivist taking care of mechanically ventilated patient should possess in the era of mechanical ventilators displaying real-time curves. So on waveforms, the very beginning of patient inspiratory effort can be detected as a sudden drop in airway pressure or a sudden positive deflection of flow. On the other hand, exponential decay of flow suggests passive condition. That means that we can assume that the start of an exponential decay of flow corresponds to the end of a patient effort. And we can use this information to check whether the cycling off of our ventilator is at the right time, too early, or delayed. So adopting a systematic method based on these and other few simple rules, after some training, it's possible to detect both major and also minor asynchronies at the bedside. And this is especially important when we want to personalize treatment in our patient. Total asynchrony time is here displayed and expressed as percent of total ventilatory time, and split into the different types of asynchronies. And you can see that for each patient that was enrolled in the study, the picture was very similar when we assessed patient-ventilator interaction with the waveform method as compared to esophageal pressure that was used in this study as reference. And this is an important point because, as already suggested in previous talk, asynchronies have different underlying mechanisms and may have clearly different impacts on outcome of our patient. So phenotyping our patient according to their interaction with the ventilator could be important to identify patients at risk and guide treatment. For instance, early cycling corresponds to eccentric contraction of the diaphragm, and this could be harmful, could lead to muscle injury. And early cycling promotes as well double triggering, that is two mechanical breaths triggered by a single patient effort, usually without effective expiration in between. And this sort of breath stacking, we now know, may be injurious for the lung, especially if volume access control mode is adopted. On the other hand, other asynchronies such as trigger delay, late cycling, and ineffective efforts are often associated with over-assistance. And it's quite clear that high level of pressure support is very similar compared to fully controlled mechanical ventilation in inducing diaphragm injury and atrophy, diaphragm dysfunction and atrophy. So, could we profit from what we see on the ventilator screen to adjust the ventilator setting? Of course, yes. If we see asynchronies usually associated with over-assistance, we should suspect that we set a too high level of pressure support, so we can try to decrease the pressure support level. And if over-assistance was the case, this is usually really effective in improving patient-ventilator interaction without any side effect on gas exchanges. Interestingly, in this same study was shown that shortening the mechanical inspiratory time was also effective in improving patient-ventilator interaction, maybe because late cycling, a delayed opening of the expiratory valve, is so common when we use pressure support ventilation. Actually, in difficult-to-wean patients under prolonged pressure support ventilation, we observe a delayed opening of the expiratory valve in more than 50% of the breaths. This is a well-known problem of pressure support ventilation that is magnified by high pressure support level. It means that the higher the pressure support level, the later the cycling off, and the longer the time the ventilator may be insufflating the patient during neural exploration, especially in COPD obstructive patients. And this may lead and may promote dynamic hyperinflation and auto-PEEP, finally leading to difficult trigger and ineffective efforts. So, if late cycling is still there once you have already optimized the pressure support level, you can try to adjust the expiratory trigger sensitivity, so change the cycling criterion, trying to superimpose the ventilator cycling flow, with the patient and inspiratory flow. Or, as an alternative, we can now ask the ventilator to do this by itself, because waveform-guided cycling off system are now available on mechanical ventilators, and if you switch on this function, the ventilator will open the expiratory valve as soon as this sudden change from fast to slow exponential decay of flow is detected. That means that our patient is already relaxed and wants to exhale. The same in the case of a restrictive patient with clear early cycling. We can adjust the sensitivity of the expiratory trigger, in this particular case moving from the default setting, 25%, down to 5% of peak inspiratory flow, and it is effective. Or, as an alternative again, select this new function on mechanical ventilator, so a waveform guided cycling valve. So we perform a pilot randomized crossover study trying to compare the default setting for the cycling criterion, 25% of peak inspiratory flow, with the expert setting, so the expert looking at waveform and adjusting the cycling criterion, and the automation. 2 levels of pressure support tested, the baseline, clinically set, and a 50% increase. But the expert setting that is here displayed in yellow and the automation improved the interaction with a decrease of late cycling. I have to say with the automation slightly outperforming the expert setting. This is flow tracing recorded from one of the patients enrolled in the study. From top to bottom you see the default setting, then the expert setting, and the waveform guided mode. With the default setting, physician observed a poor patient-ventilator interaction with ineffective efforts, the white arrows, trigger delay, the green one, and late cycling, the red arrows. So he decided to increase the sensitivity of the expiratory trigger, moving from 25 to 40% of peak inspiratory flow. And this was effective in improving the picture. Anyway, the problem for the physician, for us as physicians, is that we can select just one value for the expiratory trigger sensitivity, whereas the automation can adapt cycling off to patient needs on a bread-by-bread basis. And I think this is an important point because patient-ventilator interaction may vary over time in the same patient, and even very brief clusters of asynchronies were found to be associated with poor outcome. What about the inspiratory side? We know that the leading cause of difficult trigger is dynamic hyperinflation. That means that our patient starts a new breath when the expiratory flow is still ongoing. So, looking at waveforms at the bedside, we can detect this problem, but of course, we cannot select a negative value of flow, a negative value of flow as a threshold for the inspiratory trigger. So, no effects are expected after fine-tuning of inspiratory trigger sensitivity, if this is the problem. So to further improve synchronization in these difficult cases, we have to move from thresholds to waveforms. In other words, we have to ask the ventilator to open the inspiratory valve as soon as this positive deflection of flow is detected by the ventilator. This is a simulated COPD obstructed patient with very prolonged late cycling and ineffective efforts. And switching on the waveform guided triggering cycle, you see that immediately patient-ventilator interaction improves. And if you look at timing, now the pressure support is delivered at the very beginning of patient effort, even if flow is still negative. And another important point is that with this automation, it seems that patient-ventilator interaction is relatively independent from the pressure support level. This is important because it may suggest that even very weak patient with very high pressure support requirements may be properly assisted in pressure support ventilation. Nowadays, there are several technical solutions available on different mechanical ventilators. We perform a bench test, enrolling all the mechanical ventilators equipped with a waveform-guided triggering or cycling off system. And we observe a clear advantage of this automation, especially in decreasing the amount of late cycling and the number of ineffective efforts. A clinical trial on waveform-guided pressure support ventilation is ongoing. I can show you just an example on a real patient. This was a very difficult to assist COPD patient. You see on waveforms late cycling, trigger delay, and ineffective efforts as well. And this is with the default setting of trigger and cycling. And as soon as we switch on the automation, you see the picture is immediately changes, and all the asynchronies disappear. And when we switch back to standard settings of triggering and cycling, all the asynchronies were also back. So this is just the patient. We have to wait for, of course, for the data from the pilot study, but it seems to be a very promising tool. So to conclude, ventilator waveforms can be used by physicians to reliably detect asynchronies and optimize the ventilator settings in difficult cases, and to prevent asynchronies, probably some automation is needed. Thank you for your attention.